Okay, my name is Callie Velasquez, and this is my rapid fire case study presentation for fall 2025. Okay, so I had a patient that was a 74-year-old African male, approximately 5'5" tall. He came into the ED because he woke up with the pain, with chest pain. And he already previously had some history of, I have it here, history of a CAD, MI, hypertension, hyperlipidemia, diabetes, glaucoma, and he's also blind. But his main chief complaint was shortness of breath and chest pain. He also had a decreased speech, and his balance was uneven, and he wasn't able to stand up all the way straight. His admitting diagnosis, it was a lacunar infarct. His reason for the admission, again, it was because the chest pain was so strong that it woke him up. His admitting vital signs, it was a heart rate of 105, respiratory rate of 15, his SpO2 was 96, and I said the history already, so he has those as well. Okay, so this patient mainly had a lacunar infarct, which is a small stroke that occurs when a small deep artery in the brain becomes blocked. And then these strokes happen when small penetrating arteries, yes, they become blocked, and mostly due to chronic hypertension, which causes the small vessel to be damaged. Symptoms with this were sudden weakness and or numbness on one side of the body, difficulty with speech, loss of balance, and cognitive problems, which my patient did have, especially the speech and the loss of balance. When he was in the ER already, that's what they marked down on his chart. The effects that can be what affects the respiratory drive is by abnormal breathing patterns, and when having a stroke, they just can't really control, and it can be very serious. So this picture over here on the side is his MRI. I got it from Carolina because we do have the same patient. It demonstrates a small lacunar stroke in the deep white matter, but his brain still looks pretty normal, so they're just trying to figure out with him like what the next step for him to do. Okay, with this patient, he was intubated. He was already intubated when I started going to the hospital in Kyle. I didn't get to see him when he was not intubated yet or when they were in the process of doing that. When he did check into the hospital, he was not intubated. He was still coherent, but I'm not too sure what caused him to become intubated. I think just loss of his airway and just started to decline. And let me see. So his vent settings, it was 7.5 and 23 at the teeth. They do have the PB980 over there. He was on PRVC with a tidal volume of 500, rate of 12, PEEP of 5, and 30%. His I10 was 0.9. His I to E was 1 to 2. His minute ventilation was 7.3. His static compliance was 68.14, and his P-plat was 12. His initial lab values, they where the white blood cells, white blood count is 32.3, glucose is 1.71. I didn't get the red blood cell count. The hemoglobin was 8.7, hematocrit was 27.9. And his ABG, he wasn't able to get an arterial, but I found a venous on his chart, and it was an FiO2 of 30%, pH is 7.14, his CO2 was 29.4, and the PO2 is 58. And then the bicarb is 18.4. His SATs were 90. So the pH was in normal range. The CO2 was low, and then the PO2 also low as well, and the bicarb is a little bit low. It's almost there, but not really. And then the SATs could be better. The interpretation of that was a compensated respiratory alkalosis. So we could start by first giving him some bicarb and then seeing what we can do to mess with the vent. Okay, so this was the care that we provided for the patient. He mainly got Duoneb and sodium chloride. So Duoneb and the sodium chloride was Q4. He also did get some therapy of Metaneb. That was Q4 as well. Again, Duoneb is It relaxes the muscles around the airways to improve the airflow into the lungs. The sodium chloride is because it is able to thin out these secretions. They were pretty thick every single time that we would have to go in for suction. We had to go in a couple of times, even bronchial lavage him to get all the secretions out from him. He had a lot of brown, reddish, tan secretions. A lot were also cloudy, blood streaked as well. But that way, that medication can just get everything out of his lungs. He was on the vent for continuous when I was there, and he also did every single time we would do oral care and Medaneb as well to move out the secretions and help them just move out. And he was able to suction them easier, not being so thick all the time. So these are the x-rays that I was able to get off from his chart. The one on the left was on October 8th, and they noted that it had left basilar density, which may reflect on a fusion with the atelectasis, and there is a mid-right basilar density. So it is more darker over here. Still you see some some secretions possibly on the corners, on the inner sides. And then on the other side, on the right, we see another x-ray that he had. I believe that this one was after the one on the left, but it was persistent atelectasis or infiltrates on the left lower lung and the retrocardiac region. They also noted that there was a mild right basilar atelectasis or a developing infiltrate, but there was no pneumothorax, edema, pleural effusion, but he did have a borderline cardiomegaly, I believe. So this was the trend of the patient every single day that I would go. I was only there Sunday, Monday, Tuesday nights. So this is what I got from the chart. He first was intubated on September 19th, 2025, and that's when they placed him on the vent with PRVC, tidal volume 500, rate of 12, PEEP of 5, and 30%. Then he just still continued to be intubated. Again, like I said earlier, he sounded coarse, crackly. His secretions weren't that much, but they were pretty thick, cloudy, blood streaked. On the 26th, they decided to do a CPAP trial of 5/5 at 30%. He was able to tolerate it, but he just didn't really stay awake too much. And they would just have him on night on the vent just to give him a break, and then during the day they would CPAP him. On the 30th, he was able to follow commands, so they decided to do an SBT trial on him to see how long he would last. We had it on continuous when we were there they had it on continuous during the day. And then the patient was also doing his dialysis, so they were monitoring him for that. Then he would respond to any painful stimulus, but the whole time he just wasn't really all the way there. So they just weren't too ready to extubate him quite yet. So continuing with the track of his trend, on October 1st, he just had no acute events were happening. He was still doing okay, still passing all the SBTs. They wanted to do multiple times of seeing how he was doing to fully commit. So then they fully committed on the next day, which is October 2nd, and they switched his ventilator settings to mainly fully be on PSV 5/5 at 30%. He was doing good, but then for some reason he declined again, and they switched him back to PRVC on the 3rd of October. The details I didn't see in the chart. I'm not too sure. I don't think I was there, but they just switched him back. He just wasn't he wasn't strong enough to last long, and there were some periods that he kept going apneic. On the 4th, there was no vent changes. They still kept him on the vent on PRVC at those settings. And then on the 8th, I didn't see this, but I wasn't physically there, but on the 8th, I saw on the chart that he was actually extubated and placed on 2 liters nasal cannula. It kind of felt like they were just going back and forth, back and forth. He was on the vent for a long time. They wanted to peg and trach him, but the family just didn't want that to happen. So they made the decision that he was actually doing, for majority, even though he wasn't opening his eyes or wasn't fully there cognitively he did pass like the number values, which I didn't get. I didn't see them. But they ended up extubating him and placing him the 2 liters nasal cannula, and he did good enough to last during that. I think I was already gone by then when they did this, but I saw from the pictures of the chart that I had gotten. Okay, so the plan of care for this patient, the days that I was there, it was mainly the family wanted him to be a full code. So even they wanted him to be re-intubated. After being there and talking with the doctors, the physicians, and the other RTs, they just didn't understand why the family chose that way. They really felt like it was better if the patient was trached. But the family just decided that they just wanted him to be reintubated. They didn't want to put a trach in. They also talked and they wanted him to pursue rehab once he was fully cleared. This was after, though, since he got extubated, so they decided that yes, he would still go to rehab because he was just still declining. He wasn't really improving, but by little baby steps, and also to maintain his SATs above 94. Continue to get those chest x-rays done to check on how his lungs are, the atelectasis, and I would also still continue the medication and possibly the Metineb. That way they can just still make sure everything, I mean, from viewing the x-ray to see if everything is fully cleared from the lungs of the patient, but that's what the main goal was for this patient today. Okay, so overall with this patient, it was a 74-year-old male admitted with a CVA, a stroke, which was diagnosed with the lacunar infarct, and it was increased weakness on the right side. The patient's x-ray also confirmed him developing atelectasis, so just to monitor his oxygen, his SATs, that they stay above 90, 94, 92 even. That way he can make sure that he has good oxygenation. And also he was considered to be a patient for cardiovascular surgery to not let him have such continuous strokes back to back. But I really enjoyed watching over this patient. I felt like the staff there, they kind of had a little favoritism for him, and he was just like, he looked really frail and really, um, he was declining a little bit more often, and I just would always go into the room, talk to him, even though I just felt like he would still able to hear me. And I would talk to him and describe what was on the TV, just even though he was still intubated, I still wanted to make sure and show him that I cared. Even though I was there at nights, I didn't really see any family, so I think that's why I also felt connected because I wanted him to just not be forgotten. And the staff definitely cared about him, was always checking up on him, trying to just hope that he would get better and help the family make a decision what's best for him for his care. Since he was on the vent for so long, they just didn't feel like it was fair to keep him on the vent, kind of like a vegetable, but he ended up improving apparently since, I mean, I left and I didn't get to see him extubated. I still had him and he was intubated, but I really enjoyed taking care of him, and I'm glad that he got extubated and he progressed.